Is this on? Ooh, sorry. Testing. Okay. There we go. All right, we'll give it one more minute for people to trickle in, and we'll get started. We have a packed agenda, so I'm going to try to stay on schedule. Okay. Well, so on behalf of the International Alliance for Diabetes Action and the London School of Hygiene and Tropical Medicine Center for Global Chronic Conditions and NCD Knowledge Hub, I would like to welcome you all to the 4th Symposium on Diabetes and Humanitarian Crises. It's a true honor and a privilege to be here today. For those of you who don't know me yet, my name is Sylvia Kalenbrink, and I'm the director of the International Alliance for Diabetes Action, or IATA for short. I'm also an endocrinologist based in Boston at Brigham and Women's Hospital and Harvard Medical School and the Harvard Humanitarian Initiative. Before we begin, I would like to start with a few thanks. First of all, many thanks to the Helmsley Charitable Trust, to Gina Agiostratidou, I hope I pronounced that reasonably well, and James Reed for being here today and for sponsoring this event. We're extremely grateful. Thank you also to Sarin Events, to Chantel and Taliana for helping us organize this meeting here at this venue in Athens. And thank you to Anna, our program manager, who's been behind the scenes doing all of the work and really been such a support and help getting this planned. We're very grateful to be here in Greece. This is, of course, a country that has been very, very heavily impacted by humanitarian crises in various ways, hosting many, many migrants, asylum seekers, refugees for decades. And so we're looking forward to learning from the experience here. We have 2 keynote speakers that I'll be introducing a little bit more later, one today and one tomorrow that will be sharing more about the experience here in Greece. So So as I was reflecting on this meeting, this picture was essentially almost exactly 5 years ago in Boston. It was in April of 2019 when we had our first symposium on this topic, bringing, many of you were there actually, together to discuss this really challenging topic of diabetes care in humanitarian settings, and signed the Boston Declaration. And that's really how we launched IATA. It came out of all of you, out of this meeting, and kind of the need to want to collaborate more, work together in order to improve care as a community. And so just briefly, for those of you who may not be as familiar, over the last few years, we established, essentially it's become a nonprofit organization led by a number of colleagues. If those of you who are part of the board or team leads, would you mind standing up so that I can introduce you all? so yeah. Most of them have been involved since the very beginning. Kieran, he's now our Chief Strategy Officer. Jing and Helen are our team leads for the Access to Medicines pillar. Angelica and Aveen are our leads for the data pillar. Emma and Jay are new to the team. We'd like to welcome them. They're our new team leads for the advocacy and financing pillar. And then we have Baird, Stefan, and Lillian on the board. And Philippa and I are both co-leading the clinical service delivery pillar. So anyways, so just if you've seen the faces, please feel free to sit back down. These are the 5, we now have 5 pillars actually. We added one on leadership and collaboration, but essentially the other 4, as I just mentioned, are the same from the beginning. And there have been over 130 organizations that have been part of the group and helping. And during our last symposium in Poland, we essentially updated the Boston Declaration a little bit, just going over it and making adjustments where the group felt they were necessary to help us refine our strategy moving forward. And after the event, we were extremely grateful to have received 3 years of seed funding, many of you know this, from the Helmsley Charitable Trust to help us grow from a relatively informal organization of largely volunteers to now really becoming a more formed organization moving forward. And so we're really looking forward to working with all of you in this new kind of season of IATA 2.0, if you will, becoming a community of action together. We would love to engage all of you more and do the work that we're doing a lot more, I guess, you know, with more time, more dedicated time for all of us. And so we also, during this meeting, would love to hear your thoughts on how we can do this better, what would be useful to you. We're developing more specific membership charter. And so over the last few months, we received this grant in October. We've been building the back office, all the infrastructure for the organization, and can now move forward with the actual programmatic work, which we're really excited to do. And I would say, you know, this work is, you know, every year it's depressing. Every year the numbers seem to get worse. But just to say that this work is more important than ever. I mean, the diabetes burden continues to grow, steep upward trajectory. The current estimates are that 1.3 billion people, that's more than double of what we have currently estimated in diabetes prevalence, are projected to have diabetes by 2050. The vast majority living in low and middle income countries and increasingly affecting young populations, people in their 40s, 50s, prime of their life, half of whom are still undiagnosed. So developing complications in the background without even knowing it. This is going to be an unbelievable challenge in the future. And at the same time, I'm sure you're all well aware, humanitarian crises are, you know, continue to increase at record high levels. The vast majority also in lower and middle income countries. And similarly to diabetes, the prevalent or the estimates are that 1.2 billion people could be displaced due to climate change and natural disasters by 2050. I mean, these numbers are really mind-blowing. And so this problem is so large, any one organization or group can solve this. And resources, manpower, it's limited. And that's what we want to do, is together tackle this with the expertise in this room and others over the coming years to be able to address this more effectively. It was really encouraging in February. The World Health Organization and the UN Refugee Agency hosted a high-level technical meeting on NCDs in humanitarian settings, which I thought was it was a great event, bringing together, I think it was over 600 individuals from, you know, all over the world to discuss this issue. And so just showing the need on a high level to address this topic as a global community. And we were fortunate to host a side event on diabetes at this meeting. And so a brief overview before I introduce James, who will be saying a few words as well. Today, like I said, we'll have James Reed come up with the Helmsley Charitable Trust and share a few welcoming words. Then we'll have 2 keynote addresses, one by Timos Chaliamalias, he's the president of MSF here in Greece, and Slim Slama, the head of NCD management and the NCD department at the World Health Organization. And then we'll have 4 panels, one on the hyperacute phase of the crisis. You'll see when we talk about humanitarian settings, they're so diverse. There's the acute phase, protracted stages, transitions to the development stage due to natural disasters, conflict. There's a lot of diversity, and we would like to address aspects of all of them if possible. So we're starting off with the hyperacute phase of the emergency. Then we'll have a panel on making affordable insulin access a global reality. The third one will be on peer support and community engagement. And then the last one of the day will be on NCD financing in humanitarian settings. And then tomorrow, Lillian Chiappi, one of our board members, will be welcoming everyone. And Eleni Kakalawith, she's a physician with the National and Kapodistrian University of Athens, will be giving a keynote address. We'll then have research presentations and a panel on newer medications for diabetes and a roadmap towards creating access to those in these specific populations. And then after lunch, we'll have workshops. So I hope you were all able to sign up for one of these four to kind of hash out a plan forward more concretely for these specific areas. And then at the end, we'll all come in together to present the findings and the outputs from the workshop. And we have Ink Factory, which is a, I forget the formal term for it, but it's an artist that will be painting an illustration of the outcomes of the workshops at the end. And then a dinner for those of you who are here in person at the Dia Tafta Tavern. All are welcome. So I think, was there anything else in the way of announcements, Anna? The posters? Posters, okay. For those of you who are online, welcome also. I'm sorry, I didn't mention that earlier. But for the poster session at 3 o'clock, so today the poster presenters for the physical posters will be standing by their poster in the foyer here. And for those of you online, there's a website, Anna should have sent it around, that has all of the posters, and you can click on the different ones in PDF form to review them if you'd like. So with that, I will hand it over to, I'm going to go back here, sorry. I'm going to hand it over to James Reed. He's a program officer for the Helmsley Charitable Trust Type 1 Diabetes Program. And we're very grateful to him for coming and for being such a great support to our organization. So thank you, James.
Hi, everyone. Good to see you. I wanted to start with a really heartfelt thanks for coming here today. I feel like we have a lot of duties in our lives, a lot of busy needs, and I really appreciate you guys taking the time to dedicate this moment to a really neglected but urgent topic. I'm really excited to be here with you today at the 4th Symposium on Diabetes and Humanitarian Crises, and I'm very grateful for the organizers, including the International Alliance for Diabetes Action, the London School of Hygiene and Tropical Medicine, Harvard Humanitarian Initiative, Brigham and Women's Hospital. I like to start these meetings with a real reminder of why we're here, and that's people living with diabetes. It's easy to get lost in the details, the technical considerations, our own expert fields, but people are at the core of what we're talking about. At Helmsley, we focus specifically on type 1 diabetes, and the need is urgent. We know that in the best, most stable circumstances, people living with type 1 diabetes have a 50-year gap in life expectancy living in low and middle-income countries compared to those born in high-income countries. That starting point is unacceptable, but the difference in humanitarian settings is even more urgent. I think, as you know, people with type 1 diabetes need access to insulin, and that access is a life or death situation. A delay of a couple days can mean the end of their life, unfortunately. So our actions here today are incredibly urgent and pressing. Across the broader non-communicable disease space, a growing share of individuals are dying at premature rates, and we see that globally. Here in the WHO European region, it's estimated that over 90% of premature deaths are attributed to the 4 main NCDs: cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases. The conflict areas that are driving the highest number of refugees are also seeing large influxes of NCDs driving premature mortality. 28% of refugees from South Sudan, 50% of those from Afghanistan, 75% of people from Syria, and 92% of people from Ukraine, as an example, are all suffering and dying prematurely from NCDs. So in that sense, we need to prioritize NCDs in our emergency settings, just as we need to do in our routine health systems. But I want to acknowledge that we're in a difficult time here. I think for me, reflecting on this meeting, it was hard to think about what's going on in the world. Witnessing the mounting number of crises that weigh on us, are adding a weight on us all. We're hoping to make a difference while conflict and displacement are continuing to mount in countries from Syria, DRC, Sudan, South Sudan, Afghanistan, Ethiopia, Yemen, Ukraine. On the eve of Holocaust Remembrance Day, Israel invaded the most densely populated part of Gaza. This is an incredibly difficult and challenging conversation to have, and something I know that weighs on us all heavily. And I also want to acknowledge that the barriers to what we're talking about seem immense. They seem impossible at times, but I'm reminded of the very often quoted Margaret Mead comment saying that we shouldn't doubt the ability of a small, thoughtful, and committed group of citizens to change the world, because it's the only thing that ever has. It's a little corny, but I'm optimistic that the people in this room can make that difference. And I know this audience understands well that the prevalence of NCDs and humanitarian crises are both rising, and that puts more pressure on us to do more with less. Helmsley is proud to be working with IATA and the group of committed volunteers and partners and experts in this room to find those solutions. During this meeting, we hope to find and identify and prioritize specific and systemic solutions. How do we make the biggest impact with what resources we have available? We want to continue to strengthen the community of practice that has been built with this group across health, humanitarian, public, and private sector. And we want to keep ourselves accountable. We've set ambitious goals stemming from the Boston Declaration. We heard from Sylvia that those were refined in Krakow. We need to continue to understand how we're actioning against our own goals, where we need to make adjustments, and where we need to be working quicker. I want to leave you with 3 things to consider throughout the symposium. First, again, we need to remember that this group cannot solve every problem. The problems are immense and wide-ranging, so how do we prioritize where we can have the largest impact? Second, I want everyone to remember that no one of us in the room, no one organization can solve these problems, and we need to consider how to complement and coordinate our efforts to make sure we remain efficient and rapidly acting. Third, and most importantly, as you saw from the agenda, we're going to delve deeply into technical considerations. We're going to be thinking about big issues, solutions, clinical considerations. But at the end of the day, again, we're talking about individuals. That means families and children, that this is a life or death conversation. So please keep that at the top of your mind. And again, thank you for being here. We look forward to finding solutions in the next couple days.
Okay, so I would, with that, like to introduce Timos Chaliamalakias. I'm so sorry if I'm mispronouncing your name. Timos, he studied nursing here at the National Encopedestrian University of Athens, and he's currently working on his PhD right now, yeah. He's also working as an oncology nurse in the ICU at the General Anti-Cancer Oncological Hospital in Athens. He joined MSF in 2012 when he decided to be a member of the MSF running team, Running Without Borders. I did not know that existed, but that sounds good. And he's been working with MSF ever since. He's worked in South Sudan, the Central African Republic, as a nursing activity manager, and he is now currently here at MSF Greece on the board and serving as president since 2021. And so thank you for coming today and for sharing your perspectives here from Greece and in general with MSF on this topic of NCDs. Appreciate it.
So, good morning to everyone. Kalimera. Thank you for the invitation. It is a great honor and pleasure for me to take part in this symposium on diabetes in humanitarian crisis. And on behalf of MSF Greece, I would like to thank IADA for the invitation to address you these few words. Nowadays, 114 million children, women and men are forced and are displaced by spiraling crises around the world. The humanitarian action is targeted more than ever, and the hostile environment against non-governmental organizations is anymore a reality everywhere. In this context, we are called to take action and provide health services to vulnerable populations, to people affected by this crisis, to patients with non-communicable diseases who are not a priority for the health system in many different parts of the world, unfortunately. MSF teams this year struggled to provide adequate services to the victims of so many emergencies around the globe. In Syria, South Sudan, Chad, Ethiopia, Gaza, Afghanistan, Haiti, Yemen, Ukraine, and in so many other places, we intervene trying to respond to the medical needs of the populations affected. And we try to respond to emergencies as soon as possible. But what happens to the patients with NCDs? How efficient are we? NCD is a priority for actors like MSF. And when any other actors are not present, in Sudan and Chad, as MSF, we could say that we are facing the biggest humanitarian emergency we have seen in a long time, and there is a vacuum and an absence of other organizations. There is a clear need to integrate care for non-communicable diseases, including diabetes, into emergency responses. It's crucial to provide a platform for stakeholders to discuss best practices and align implementation plans. And therefore, we are all here. And this symposium needs to give the space and the opportunity to all of us to exchange experiences, share information, and give the space and opportunity to find common pathways in order to improve the provided services to all our patients around the globe. The NCDs cannot become neglected diseases, and therefore efforts have been made the last years, and these efforts should be reinforced as the context changes. Ladies and gentlemen, during this symposium, several experts will offer their views on the different roles and responsibilities played by national actors, by the international community, including agency, private entities, governmental and non-governmental organizations, to the management of the diabetes and other NCDs during the humanitarian crisis. As myself, I am not a medical expert for diabetes. I'm not going to spend your time for sharing data and new scientific updates, but I will profit this opportunity that was given to me to be here in order to share with you my own experience from Greece. I'm a medical person. I'm a nurse working in the public health system the last 10 years. Whilst I had the advantages to provide my services to vulnerable populations, to people on the move, in Greece and in African countries during a period of crisis. And I can now admit that anywhere I work, I always have the same doubt about our medical services. How do we really raise our patient voice? How do we really treat our patients, giving them the space, the time, the opportunity to realize the situation, to ask their questions? The absence of intercultural mediators in many parts, the communication gap is constantly unmanageable and sometimes creates barriers which cannot be demolished. This is a problem for many people, refugees, migrants, asylum seekers, people on the move in general who cannot have a complete access to the health system. In Greece, these patients who have diabetes, who have any other communicable disease, cannot communicate efficiently inside the health facilities. So, how easily can they follow the treatment plan? How easily can they describe their problems, their difficulties, and their anxiety because of a prescribed treatment? And now, let's go deeper in the Greek reality and let's think about a humanitarian crisis, maybe different of those to which I was referred above. Since 2014, 2015, many people crossed the Mediterranean Sea and or tried to arrive in Europe passing through the Greek territory. Many of them continue their journey, staying to the country for some days, months, or even years, while some others were forced or decided to remain in Greece. Despite the political changes, the last decade, we can say that these people never had full access to the public health system. The patients with NCDs couldn't have access to all needed diagnostic examinations, to the required treatment, or even to specific specialized doctors. And now let's think to another interesting part. This period, that period, many different medical actors, NGOs, or volunteers, or private public organizations offered medical services to these populations, treating emergency cases at the beginning and later on trying to respond to chronic diseases like NCDs, including diabetes. Despite some efforts, we never succeed to maintain a common recording system of these patients, resulting to the duplication of the services, the overlapping of the provided treatments or advices, and for sure, the waste of resources. And this is the reality for a European state where the health system faces many challenges after 28, but still remains in a problematic situation. How can we respond to these challenges, not only here in Greece, but in more unstable and insecure contexts? How can we work in a more collaborative way in order to use more efficiently our limited resources, providing at the same time the best services for our patients? How do we educate and empower our partners and our patients in order to be able to respond adequately to the NCD's specific requirements? As a matter of fact, the NCDs are forcing us to think very differently. They compel us to think about how to organize a new international response and who to engage, how to find different ways of acting, and to be closer to the societies. Dear participants, I would like again to welcome you here in Athens from my side for the fourth annual Symposium on Diabetes and Humanitarian Crisis, and I wish you to have interesting, fruitful discussions, debate, and exchange the following 2 days. I wish you a successful Symposium, and thank you for the invitation. Thank you.
Okay, now I hope we have Slim Slama online. There he is, yay! I don't think Slim needs an introduction. I think we all probably know him, but I consider you, Slim, the godfather of NCDs in humanitarian settings. He is the head of NCD management in the NCD department at the World Health Organization headquarters. Prior to that, he worked in the regional office for the Eastern Mediterranean based in Egypt. And honestly, I think Slim has been just such the pioneer in this space. I credit Slim with the establishment of IATA. He came to the first symposium in 2019 and just a phenomenal, wonderful collaborator and colleague all these years. And so we're incredibly grateful to you, Slim. I know you're very busy these days. Thank you for joining us today and for sharing a few words from your side. We really appreciate it. Over to you.
Thank you very much, Sylvia. Good morning, colleagues and friends. I'm a bit emotional because this is indeed a journey that I shared with you since the beginning, and also because I'm about to close my own personal journey in WHO after more than 10 years of services. I will be starting a new adventure back in the Middle East, where I come from originally. But I must say that I measure the path that we have taken together, and as many of you have already highlighted, we made some strides, but still a lot need to be done with what James and colleague have highlighted. The focus on people and where people live, to contextualize, as Timos just mentioned, I think taking into consideration the profile of the population that we have to serve, but also the health system. And a couple of years ago, I was in Athens. The last time I visited Athens was with Doctors Without Borders. And for those of you who have been working with MSF, they used to have something called the FADs, the Field Associative Debates. And I think this is a bit the same spirit of the IATA Symposium, is to really share, because no one, not a single organization, not WHO, not any of the UN agencies or the partners in humanitarian organization that are providing humanitarian relief assistance can tackle this alone, as was mentioned. I think I will not go back to the figures. I think the framing has been done, but maybe highlight perhaps some element of the contribution that WHO, and from our perspective, what has been done, some areas where we need probably to focus on better. But I think the starting point is and will remain people, and how also we better engage them in framing their needs. I think there will be a session later today on community engagement and participation, and we also learned, even as a UN agencies, originally we interact with the member states, with government, with ministries, but I think being able so to mobilize communities, people living with diabetes has also, we learn a lot in the recent years, including in emergency, and some of the colleagues in the room have been at the forefront, being themselves living with diabetes, but getting their insight about the needs, the difficulty, the challenges. I'm myself directly involved now in the response in Sudan, in Gaza, and we have seen how much also the communities and their resilience is remarkable. It can help us also better understand. I think this is perhaps the starting point. The second, and I keep on saying this the same, I'm a bit on a broken record on this, is that making the right investment towards universal health coverage and resilient health system is really the foundation of it. And I think as we are speaking about our ability to respond in crisis and the acute response, I think we need to consider that pre-existing health system, the financial and human resources, the medication availability, and of course the characteristic of the population that we serve in each setting varies. And humanitarian crisis just act as an additional risk magnifier of people living with diabetes. I think that aspect of the vulnerability of people with NCDs, we have seen it during the COVID pandemic, is still not sufficiently acknowledged in emergency preparedness and response. And this acts also across the continuum from prevention to treatment to exacerbation of pre-existing condition of the patient, but also highlighting pre-existing deficiencies in health system. I think countries who are making investment, progressive realization of UHC for diabetes care in particular, for the large population, including those who are forcibly displaced, as Timo's just mentioned. I mean, benefit and entitlement for refugee population, given the protraction nature of most of the crisis now. I mean, people are displaced for decades, and we have to find solutions that not only guarantee some essential services of good quality, but also with financial protection. And in most of the situation, including in a very protracted situation like in Yemen, in Afghanistan, we know that 70–80% of financing is private. Privately, when I say private, it's not private sector, but it's really about household, about families, about patients having to pay out of pocket, contributing to catastrophic expenditure. And this is really the core of the work, is to define what are those essential services across a continuum of care. For people with diabetes, is often around bundling, not only medication, but also diagnostic. I think this is some aspect that are the core of the discussion. When it comes to WHO and how we frame it, more and more we are trying to bring convergence between, I would say, the health security agenda, the health system strengthening agenda, and that aspect of resilience. And you might have heard around a framework, and of course, many of those documents are there to conceptualize thinking idea, and very much around what YADA have done with the working group and the thematic that you are trying to tackle. But at large in WHO, we have issued last year something called the Health Emergency Preparedness, Response and Resilience, which is a very complicated wording for something that actually aim to say how can we better align resilience building, health system strengthening, and emergency preparedness activities to really try to improve health security from one end, but also mitigate the risk to the population and build that foundation. And I wanted to use this perhaps as a way to highlight where I would see more work to be done, and building also on what we have done so far. One is to progressively acknowledge better that people with diabetes are really considered as vulnerable group, and for both diabetes but other NCD condition, as James mentioned, the need to really include NCD, diabetes, national and subnational health emergency and preparedness and risk management plan. So that is not something that comes ad hoc, which is still the case, but really fully implemented, fully included in emergency planning. Some aspects require also that legislation, as we mentioned, specifically in countries like in Greece, ensure that refugee displaced people and people living in humanitarian crisis have access to an essential set of NCD services, including for diabetes. That regulatory framework, and we have seen it in the situation of Ukraine, allow medical evacuation, mobilization of international workers, and surge capacity for emergency procurement. And that also the resource mobilization, and you will have a full session. I think I really look forward for the deliberation on NCD financing in humanitarian and in diabetes in particular, because the current structure, but also the way the funding for acute emergency versus more protected crisis is set up at the moment, do not fully respond to their needs. And as I mentioned, in countries, specifically in fragile, conflict vulnerable settings, where that linear model about moving from acute to protected or to recovery does not exist. And there are cycles of crisis intertwined of different nature. We need to think around still maintaining capacity to provide those acute response and maintaining services, but also building them at the first place and being able to agree on a minimum set of essential services that progressively can be subsidized so that people do not have to pay at the point of care. And I think this is, as I mentioned earlier, a core element. In the recent years, what we have done is really to be able to elevate that discussion of diabetes in humanitarian settings and NCD at large, using also the platform, the World Health Assembly, and the UNGAS in particular, where member states in particular, but also UN agency and the other partners are discussing this. Sylvia have referred to the global high-level technical meeting that we organized. This was just a culmination of years of advocacy to really try to highlight first and document what's happening out there in more than 65 agreed emergency we responded to in WHO in the recent years. We try really to first thank to the work of colleagues and also IADA, what's happening in terms of provision of care across the globe, how are countries prepared or not prepared actually to integrate this, and how can we improve our operation. So that advocacy and the coordination aspect, the convening role also of WHO have allowed us also to better understand first the situation, but also being much more operational in the response. And I think this is where the meeting in Copenhagen in February was meant to bring the emergency, the humanitarian communities with the NCD1 and the kind of development humanitarian nexus, which doesn't necessarily meet, and being able to build on that to say that this is something that also people working in diabetes, people that are more related to provide the provision of NCD care need to understand how do we make an assessment of the risk during an emergency, how an emergency response evolve, and how as part of the operation response we can better collaborate between health system and emergency community. At the global level, I think we have managed to get it, I think, where we wanted this to be at the level of the World Health Assembly and the UNGAS. We have had a couple of resolutions, both on, of course, diabetes a couple of years ago, but more specifically also on NCD in humanitarian settings with some recommendations that are really for us extremely important, because when member states sign for it, it's a starting point to create mandate, to create a work, and we have a joint work plan between the emergency program and the NCD1 in WHO, with now all the region trying really to contextualize their approach and the roadmap. So this is part of the advocacy. I think IADA contributed massively to this early on. Also, as I mentioned, the importance of research and documenting country experiences, and the series in The Lancet a couple of years ago was, I think, at the forefront of this, allowing us also to understand better and getting some figures. Timos was referring to continuity of care and data system. I think it's a very important area that we need to unpack, and one of the work stream of VIADA. And people think often that we need data during emergency. No, we need to use mainly pre-existing data, pre-crisis data as much as possible. Of course, there are some elements related to service availability during a crisis and some tools that exist to monitor this. But the disease profile, the registers often do not exist at the first place in most of the low and middle income countries. And this is an area of investment, of data system to capture the process of care, I think is critical and still not necessarily there. And during emergency, of course, this is often disrupted. So being able to think out of the box about models that allow us to have that continuity of information as much as possible is something that require much more focus, but also on stockpile analysis of medication, the markets that pre-exist. We have done it in Ukraine and in other places. And this has really helped also the emergency response when we are prepared. Because specifically when it comes to emergency procurement, I think that aspect of information and pre-existing information on the health system is a critical one. The other point, perhaps as as an entry point, is really, as I said earlier, being able to be closer to communities and to local solution. I think most of the funding, and we are about to have an important meeting as part of the process leading to the high-level meeting in New York on NCD at large in 2025. We have a series of global meetings. The NCD in emergency was only one, but we have one coming with the World Bank in June on NCD financing. And we see that most of the financing, of course, is going to multilateral agencies, international NGO. I think it's a good thing, but at the same time, we should be able, as James mentioned, to support communities, group, and also organizations like IFRC and others that are embedded in communities and supporting community response. And in our work also trying to mobilize more that support community groups, the people living with, to better understand also the needs and generate solutions for service delivery during response and recovery. A critical point that I think remain a bottleneck, specifically for diabetes, is that access to what we call in the HEPA framework the countermeasures, basically the supply chain and the procurement of essential medicine. I think for diabetes, as we have seen, that importance of bundling both medication and medical diagnostic is key, and also the ability to have that priority list of medicine and diagnostic at the first place, being able to adapt and align as much as possible when this exists, the national essential drug list, the national guidelines and protocol, and also understanding the market in a given country pre-crisis, being also able to reach out as we did. We have a long-standing relationship with the private sector, being able to engage also the private sector. I think I've seen in one of the iteration of the program, I think the challenge of insulin and medication at large. I think we are, despite 2 years ago that report on the century after discovery of insulin, we are losing the market of human insulin. I think this is something critical both in stable and humanitarian settings, and I think we need to be careful around also how we frame the discussion on access to medicine in particular. We need to push the boundaries in terms of price reduction for analogs, but we need also to understand that in many countries, this is a far reach, and in humanitarian context, as we are responding now in Gaza, in other places, in Sudan, in DRC, in many of the acute emergency at the moment, we still need to have drugs that are still effective, that are cheap, that are generic drugs, as well as being able to test whether analogs, a new way of delivering also these drugs can be tested. But I think being able to have a core response of a minimum response, being able also to anticipate, because we don't anticipate, and I've seen it now several occasions, that the delay in procurement is not only because of the time of procurement, because also the orders, the anticipation, the prioritization has not been done sufficiently early. And I think this is where we need to train our emergency teams, our colleagues, and all the people that are involved in procurement in having that early focus on procurement of essential medicine, buffer stocks, deployment maybe of kits like the NCD kit, but also being able to anticipate the cold chain requirement like we have seen recently, I think in many places. Even if we have the drugs, they're often in warehouses, and the warehouses do not necessarily have cold chain requirement, and distribution becomes also delayed. And the last point I wanted to highlight is the care and the model of care and the essential component. I think you will have a session later on that minimum service package. Can we agree? And there had been different attempts, including in WHO, some of the programmatic areas that we learned from, whether on sexual and reproductive health or on mental health more recently, have developed what we call a minimum essential or a minimum initial package of services. I think it would be important that we contribute as well to say what could be the core element that define an essential package that is contextualized according to guidelines protocol that exist or not, but also being able to have a service model that is adapted to the context and feasible within different type of emergency, and how community health workers and the health workers at large, including our emergency medical teams in WHO, we have this system of recruiting emergency medical teams, but most of them have been geared towards critical care, emergency care, and trauma. I'm very happy to see that Timos, for instance, is an exception, having people trained as nurses, doctors in NCD, and having that background is critical to make change happening on the ground. And I think we should invest much more time in building capacity across the board, including on emergency medical team. With this, I think I wanted to say that we have done quite a bit, and YADA have contributed significantly to that debate. There's still opportunities to strengthen the health emergency preparedness response with, as I mentioned, much more focus on also protracted situation where the foundation is really on strengthening the health system at the first place. The policy should highlight that vulnerability that is peculiar to people living with diabetes and NCD at large, and integrate this in emergency preparedness and response. And this is why we're supporting. And there is a priority action across, some of those system building blocks and some of the streams that YADA is already covering, I think, to tailor diabetes care and offer an opportunity to really contribute to the emergency preparedness risk solution. And I really look forward to see the iteration of 2.0 of YADA. I think you have done a great job, and look forward to support you as much as I can in my new endeavor. Thank you very much, Sylvia, for giving me the floor.
Thank you so much, Slim, and really appreciate your words and your wisdom. We wish you were here. We do also, I think on behalf of all of us, wish you all the very best in your next stage of life. And we absolutely hope to keep in touch with you.